Welcome back to Stop Feeling Like Shit. And I'm your host, Danielle LaCourth. And guess what? No Dr. Buzz today, but we do have in the house Joe Matovich and Tiffany from Buckeye PMR and Anti-Aging. And today we're breaking down the bro science, cutting through the confusion, and giving you the real functional medicine truth about restoring energy, drive, body composition, and long-term health, and what really matters when optimizing male hormones. If you're a man listening or you love a man who's struggling with fatigue, low libido, ladies, poor sleep, mood swings, or stubborn belly fat, guess what? We got your answers on this episode today. All right, let's get into it.
All right. So when we're interacting with men, some of the biggest symptoms that we interact with, I would definitely have to say, are low libido, fatigue, feeling like they are in the gym constantly and not putting on muscle and not losing belly fat. What are some of the ones you see?
Big one we see is mild depressive symptoms, anhedonia, reduced motivation. A lot of guys, when I'm talking to them, always say, I want to do these things. I want to go to the gym. I want to do stuff around the house. I want to do this. It's a lot of intentions with inability to act on it, where they just feel like they can't do the same things they did previously. Like you said, sexual dysfunction is a big one. Belly fat, loss of muscle mass, joint pain and inflammation tends to be a pretty consistent complaint that we see too. Right?
Perfect. So when patients are coming in with these complaints, the normal thing that we do is blood labs. With testosterone, I would say total and free testosterone is something that is pretty black and white, unless those lab values are looking good and they're still symptomatic.
Right.
So when we start moving patients into hormone replacement, we have a couple different modes that we use. Injectable is an option, pellets. There is a cream option, which we'll kind of dive into each one of those. Let's start with creams.
Let's start with creams. Yep. So as far as, and I'll even take it a step back, we'll talk about maybe lab evaluation,
Sure,
if you're okay with that.
Yeah.
So, when we look at assessment of testosterone, we're not just looking for, testosterone values. We're looking for total, we're looking for free, which is basically what do you make versus what's available. Some guys, we got to go further down and look.
Let's stop at that a little bit more. So total, which is the number that a lot of people talk about, right?
Yeah. Yeah. Total is the number that everybody gets hung up on, I would say, because it has nice, it's like window shopping.
Big numbers,
it's a big number, right? So total looks good on paper. Whenever you hear guys that are like, oh, I want my test to be 1,000, right?
Right.
It's clinically not as significant, though. Not that it doesn't matter, but it's not what we really base our titration off of. What we really want to focus on is your free testosterone, which, for anybody listening, when you look at your total testosterone, it essentially out of the gates is going to have a couple different avenues it can go. Some of it is going to get aromatized, which means it turns into estrogen right out of the gates. A lot of it, and in fact, about 98% of it is a bound hormone, which means we have different carrier proteins, most notably what's called sex hormone binding globulin, that attaches itself to that hormone. Now, the reason that's a problem is once it's bound to it, it won't separate, and then it can't interact with the cell. So we can measure it as part of the total, but metabolically, it's useless to the body. And then what's left over is the free. The free is the metabolically active testosterone that will turn into things downstream like your 5-alpha and your 5-beta DHT and metabolites from there. So that's really what matters. For example, a male patient with a total testosterone of 800, but a free of 25 has a better profile than a guy with a total of 1,000, but a free of 15, right? Even though the 1,000 looks more impressive, the free value is really what dictates more as far as care. Right.
So how do we know when they are low?
When they're low. So obviously blood is what we look at, right? Blood is what we look at.
I meant value-wise.
Value-wise. So it's, so we'll look at total, we look at free, SHBG, estrogen, we look at pituitary function and things like that as well, we'll get to that in a second, differentiating what's causing low testosterone. But when we look at low values, we're really focusing on free testosterone, right? Mm-hmm. So in our clinic, somebody could have a clinically normal testosterone, a total testosterone that's low normal, mid normal, even upper third normal. But if their free is running low, that's what we're going to treat on. And what we use, our free range is 8.7 to 25.2 or 26.3, depending on age
group.
Depending on age. Yep. Other labs may use different units of measurement where we're in picograms, some are in nanograms, which would be more like the 52 to 280 range, right?
Yeah.
So when we look at evaluation of low testosterone, like we're really looking at two things, right? We're looking at not only is the value, where does the value sit, and then what do the symptoms correlate to, right? So the symptoms is a big piece, right? When you have somebody that, let's say their testosterone or their free is bottom third, right? Or bottom quartile even, but they subjectively feel fine, right? They feel great. Their mood's great. Their workouts go great. Libido's great. That may be somebody where they consider that HRT, they don't feel like pursuing that option right now because they subjectively feel fantastic, right?
Which, I mean, theoretically, they could just be using a lot of that into DHT or something like that. So the free testosterone value doesn't necessarily indicate
the whole picture.
Yeah, correct.
Right. But in that same scenario, if we have a patient that's bottom quartile normal range and they're really symptomatic and we say, hey, yeah, this is low normal, but we could safely increase this by 250%. And them get significant benefit and be safe, like, yeah, we're going to do it then. So.
Absolutely.
Right.
Okay. So a patient, and there is clinically low values also. So there is free testosterone, which is low. So let's just talk about them because that's the easiest group for us to talk about management with.
Yep.
So when they're clinically low with total and free,
right,
we obviously are going to be recommending hormone replacement.
Right.
And that's when we're going to move into modalities. So the first option would be creams. We are hesitant in general to offer creams for a couple different reasons. Number one, consistency of use is rough because that means that you are going to be doing daily application, sometimes twice daily. And consistency with utilization of creams is just not as compliant. Second is obviously catching value with the free testosterone because we want to make sure that they're an optimal value, but creams are in and out of your system much faster.
Right.
So catching to make sure that they actually are feeling good and their lab values are looking good.
Right.
And then there is the interaction with hair cells, which is a concern because you could be creating DHT aggressively. So then you could be losing your hair, et cetera, et cetera. And also passing it off to other people. So if you have testosterone on your chest or something like that and you hug your wife, you could possibly be transferring a pretty significant dose of testosterone to them, depending on when you applied.
Yep. Biggest concern, especially being a small kids too.
Absolutely.
Right.
We've heard horror stories of babies picking up testosterone and things like that.
Yeah. Yeah. Which causes all sorts of fun stuff like precocious puberty and genital changes and things like that. So
yikes.
So not something that we want. You know, and we don't use a lot of creams at our office. Previous office I was at, use them a little bit more, but I would just say for male patients, the potential for side effects, like you said, that people worry about, hair loss, benign prostate enlargement is highest with those modalities because of the DHT conversion with them. And, if anybody wants to know why, because the enzyme that converts testosterone to dihydrotestosterone, which is a great metabolite, the most active metabolite of testosterone we have, but is associated with hair loss, is extremely abundant in hair follicles. So slapping a bunch of testosterone where you have body hair is kind of asking for problems.
So not saying that we don't do it, but very rarely offer it.
It's not our preferred method.
Correct.
Yep.
Next tier is pellets. Pellets definitely has the most convenient factor to it, right? You come in for a procedure every 3 to 4 months, and then it's just hanging out in your system. You may only have to consider gonadorelin or anastrozole, which we'll talk about in a little bit. The con to that is the experience of testosterone is a little bit different, right? So when you're experiencing the release of testosterone throughout a duration of time, it's peaking at about 1 month and then slowly troughing off for the remainder of month 2 and month 3. So the rise and fall happens a little bit more gradually. So there's a little bit more of a lag time period in the trough section.
Right. Yep.
But definitely if you aren't consistent with taking medication, if you forget to do things all the time, like that would definitely be the best option because then you're not in control.
Right.
We are.
Yeah. Yeah. And that's the pro and the con of pellets, right?
Yeah.
Is once they're in, they're in. So your window of adjustment and titration is more narrow, kind of once per round. But if you take your testosterone and consistently, it's not going to work.
Right.
Right. And then you've basically disrupted your endocrine system and then not replaced it. So,
right.
The other thing with pellets, you could argument, I think that I personally like them a little bit more for female patients than men, just by the volume of pellets that are needed to be used. So, anybody listening not familiar, they're little bioidentical compound pellets. They're about the size of a grain of rice each, and they're inserted in the fat in your butt cheek. And
then they hang out there and dissolve.
Slowly over time. Female patients may get away with, a couple estrogen pellets, 2 to 4. Men may need 15, 17, 20. I think the highest I've seen is 25 to get therapeutic. So there's a little bit more in there from a volume perspective too.
Yes. The other concern is that some people slowly over time with using pellets will slowly reject the pellets, which is an interesting concept, but it's like their body slowly acknowledges it and gets rid of it, which could be an autoimmune component or something to that nature. But in that circumstance, if your body starts rejecting some of the pellets, then obviously you're not getting the benefit from the pellet itself.
Yeah, all of a sudden they're pushing them out, which is weird. Yep. So
not a rare,
super uncommon,
but seen it.
Yep.
Last option is injectables. So frequency on that could be anywhere from once weekly to biweekly being twice in 1 week, not every other week. Or you could do sub-Q more frequently. So anywhere from 3 to 7 days. And the theory on that is obviously the experience of testosterone being as rise and fall a little bit shorter. So it's a little bit more stable. And then obviously if you do it daily, it's keeping it the most stable. Just again, more dependent on how capable you are at taking medication consistently.
Right.
With that, there is a couple different options on esters that we interact with. So there's the cypionate and enanthate, which are the ones that we work with the most.
Yep.
Just depending on how quick the ester acts, essentially. So if you're somebody who would be doing a more frequent injection, which I'm sure you want to elaborate on that more, but enanthate could be more beneficial because it's a little bit faster acting. Or if you could use a blend, that would be beneficial as well. So we have an enanthate cypionate blend that we use.
Yeah, and all esters really are just they control the rate of the metabolism of the drug. If you're going to inject what's called a test-no ester or a testosterone suspension, which is probably known in the bodybuilding community, it would be a rapid spike and trough, right? It'd be something that you'd have to administer every day, probably multiple times a day, with a big spike and a big fall. So adding those esters into the drugs helps control the rate of metabolism of the drug to provide some level of stability. Now, that being said, I feel, and I'm sure you do too, and most of our patients we do, even with injections, we recommend a more frequent administration schedule than once a week. We do see patients coming in from other places once a week, once every 2 weeks, which is really
Feels
crazy.
Very primary carry.
Right. And when you look at the different ester blends of the drug, the half-life of the drug, the elimination half-life may run between 4 and 8 days, depending on variable rates and in individual metabolism, right? But your peak blood concentrations with like cypionate, for example, may hit 24 to 72 hours after an injection. And even with an injectable testosterone with that ester, your trough to peak change may be 300 or 400%, right? Which means your peak to trough is going to be an equally big drop.
And some people do feel that.
Yes. Yep. So a lot of times, even on the once a week injection, patients are like, day 2 and day 3, I feel like I could run through a wall. Everything's great. Day 5, I feel average. By day 7, I'm tired and lethargic again, right? We also, want to consider what are the things that you have to manage with testosterone, right? That you have to be cognizant of, right? And it's the transient peaks in the other metabolites of testosterone, right? One of the big ones being estrogen, right? So estrogen predominantly stores in fat cells, and it does clear a little slower, it seems like, than testosterone, right? Because of that.
Definitely does.
So when you're going to aromatize or convert the most estrogen is in that transient peak. So if we can minimize those big peaks, we're going to minimize also how significantly we see the ill effects of like estrogen accumulation, giant spikes in DHT values and things like that, and overall stability and therapeutic response.
And honestly, a higher value with your free testosterone.
Yeah. Yep. And the more frequent the dose weekly, the more closely we're actually replicating natural physiology, right? So big difference between once a week and twice a week. Huge difference. Obviously, I'm on TRT. I feel a huge difference when I split my dose up to twice a week. I continue to notice difference when I take it 3 times a week. I tried doing it every day for 7 days. Although my level was probably more stable doing a small dose every day, I would say that subjectively how I felt, the difference between 3 days a week and 5 or 7 days a week wasn't significant enough to me to warrant doing an injection every day. Every day. Now, different patients respond differently. So what's true for me may not necessarily be true for another patient. We have plenty of patients that want to do it, sub-Q every day, microdose it. And that's great. And that's probably the closest to what your body would naturally do on its own. It's great for mitigating how much AI or if any AI, if you need to do it in stability of your levels. I just personally didn't feel the difference enough to do it every day.
For sure. So fluctuation on a day-to-day basis for males looks like what?
So we have to understand what drives the testicles are our primary testosterone producers. Most testosterone comes from the Leydig cells on the testes. Anywhere from 5 to 30% can come from DHEA from the adrenal glands, but most of our testosterone is testicular sourced. Mm-hmm. And the testicles are just doers. They just make stuff, but they don't self-regulate at all, right? So what really drives them is the communication loop between the hypothalamus, which is part of the brain, the pituitary, and the testicles themselves, that big loop of stimulus that's called negative feedback. So generally speaking, the hypothalamus and pituitary are going to be most active at nighttime during REM sleep and deep sleep, okay? So testosterone values, generally speaking, will be highest first thing in the morning, right?
Which is why insurance requires labs to be drawn first thing in the morning.
And I was going to say, most patients may say, hey, or insurance companies want it 2 labs before 10 a.m. to verify that it's low, which sucks because we've seen patients where their total test may be 700 or 600 at 8 a.m., but it's 300 at 3 p.m., right? So they still feel
getting crushed throughout the day.
And it drops a lot. The other thing that influences testosterone as far as variance is that natural communication loop between the brain, pituitary, and the testicles. So if you were going to evaluate test levels relative to LH, which is what's called luteinizing hormone, that's what tells your testicles to make testosterone, okay? Our whole body runs on, or our testosterone runs on this big negative feedback communication loop, which means hypothalamus, pituitary are going to keep sending stimulus via LH to the testicles, telling them to make testosterone until something tells them they don't need to anymore, which for men is, generally speaking, it should be an adequate level of testosterone. Now, estrogen can also provide negative feedback and things like that too. So it's not just testosterone, but for argument's sake. So if you looked at kind of the curve, or you graphed LH and testosterone over the course of a day or a week, what we would see is, LH would climb and then testosterone would climb. And then as testosterone hit a peak, LH would start to fall because the brain would say, okay, testosterone's good, let's stimulate the testicles less. And then as testosterone started to fall, the brain would say we need more. Then it's going to tell the pituitary to work, and LH is going to go back up. So we're seeing this kind of ebb and flow between LH and testosterone where they move kind of opposite each other. If testosterone's good, LH is going to go down. As testosterone starts to fall, LH is going to go back up to bring it back up. So, not only do we have changes in daily testosterone expression, just because of when the hypothalamus and pituitary are most active during sleep, but we're also going to have this continuous loop of communication where LH and testosterone kind of ebb and flow against each other based on the body's need for testosterone production.
So then clinical hypogonadism is LH constantly cranking and testosterone never meeting the need.
Right. Yeah. So that's where you get in bringing that up gets into, there's really kind of two causes of low testosterone, right?
Right.
There's primary and secondary hypogonadism. What you just described is primary hypogonadism. Pituitary is working overtime. LH is sky high. Testicles are being told to work, but testosterone is not being secreted, right?
Correct.
That means the stimulation loop is perfectly intact. The Leydig cells no longer work well, right? And I would say that's the analogy I always tell patients. That's like, we got the gas pedal to 4 and the car's going 20, right? Stimulus is there. Yeah, and that's all it's got, right?
Giving it all it's got.
Right. And that's primary, which means the problem is at the testicles. Or you can get secondary dysfunction, which we see a lot in younger men, which is
like a lot,
which is where the testicles are structurally and functionally intact, but the communication loop is essentially broken, where something has caused the hypothalamus and the pituitary to no longer respond appropriately to what the testicles are doing.
Which most commonly is TBI, right?
Yeah. So we see TBI, concussion head injury in a lot of these patients, which is why we've got a ton of first responders, former military, former contact sport athletes, fighters, chronically high levels of stress, right? We know is CRH, corticotrophin releasing hormone, goes up. It pushes GnRH down. So chronic stress can suppress that communication loop. Circadian rhythm disruptions, poor sleep,
environmental actually is becoming a hotter topic in that conversation as well, because we're seeing that younger and younger now.
Right. And that's the $1 million question. Is it glyphosate and microplastics and
I was going to say, is it the plastics?
Right.
Is it the pollution? Is it like, what other influencing factors do we have that we just don't even have enough research on at this point?
All these wonderful endocrine disrupting chemicals.
The hormones in your food, et cetera, et cetera.
Right. So, and that's the $1 million question. And that is interesting, because even when you look at like normative data on testosterone, I'm speaking in regards to total, the normal range for the CDC now is 264 to 916. Up until I think 8 or 9 years ago, it was 348 to 1197.
Which is kind of crazy, because then it's like we're looking at an optimal value, but optimal has changed based on normative.
Right. So where we look at it, we say, okay, well, if the normal values that normative data is based on a healthy adult male population ages 19 to 39. So interesting enough, although it is the Center for Disease Control, they reassessed standards, but really didn't ask why. Right. So
they didn't have to ask why, right?
Right. But a logical person could say like, hey, if testosterone has dropped 30%,
that's a red flag, giant red flag.
With the youngest generation of males now participating in new data studies, isn't that an alarming trend for the overall health of young men?
Absolutely.
But it's not. They just it's like moving the goalpost, right? We're playing the same game the goalpost moved.
So theoretically, if we continued on this trend, they would be changing the normative data again.
Yeah. Right. And that probably will come. And that's, a lot of people have heard anecdotally, oh, well, if you look at, your male counterpart 30 years ago, on average, they'd have 30 to 40% more testosterone than you do now. Yes.
Yeah.
Yes. Right. So we as a nation continue to get less healthy. And instead of addressing the root cause, we just move the goalpost.
But not in a setting cool new goals kind of way, in a depressing, we're settling for something worse kind of way.
Right.
Which is
wild. So it is crazy. And we always take that with a grain of salt as well when it comes to treatment.
Absolutely.
Right. Is good and optimal, or normal and optimal, definitely don't equate to necessarily being the same thing.
Which either way, there should be a sliding scale, right? An 18-year-old should definitely have more testosterone than an 85-year-old.
Right.
But an appropriate scale in that category.
Right. No, I agree with that. So, and yeah, it's just how the CDC works is crazy. But yes, back to your original point, what we see in most young men is secondary dysfunction, which means, at least what you can tell from a laboratory standpoint, the testicles appear to function fine. There's just the gas pedal's broken out the engine.
Right.
Yep. So
when we're doing hormone replacement, with using testosterone replacement, we're essentially stopping that cycle.
Right. And that's something that we always like to consider with care too. So
Yes.
yeah. So like I said, that negative feedback communication loop, that as needed communication, when you administer testosterone, once you hit a therapeutic level, eventually the hypothalamus and pituitary are going to say, hey, well, we got enough testosterone. So now we no longer need to stimulate the testicles, because your body does seek equilibrium, a balance, and your body does think there is such thing as too much testosterone.
Right.
So if your level is adequate, right, or it's at a therapy, and that negative feedback point may be different for everyone, right? But with care,
which is why you pay attention to symptoms and things like that.
Yeah, but pretty much with almost all patients we've seen, you will eventually reach a level of maintenance where hypothalamus and pituitary shut down, and unless you do something to combat it, LH goes to nothing and stimulus to the testicle stops.
Which is what you'll see on labs.
Right.
You will see an LH that is minimal to
undetectable. Yeah,
correct.
less than 0.3 or whatever. Right. Now, and then that brings into the next concern that a lot of patients have is, what if I don't know I want to do it forever? What if I want to have kids? What if I want to do things like that? Right.
Right.
And I always, the testicles are like any other tissue in the body, right? If you're not using them or there's not stimulus to them, they're going to go metabolically dormant. Some of the cells are going to atrophy and become less active. Some of the cells may die, right?
Right.
Because nothing is telling them to work, right? Kind of oversimplified, metaphor, as I always say, for a patient, it'd be like, if I tied your hand behind your back for 5 years and at the end of 5 years said, all right, go do all the same stuff with that arm you could before. Like, that would clearly not be a realistic expectation.
Would not be.
Right. You'd have atrophy and tissue loss and all sorts of dysfunction. Testicles are kind of the same thing. Like, the longer they lie dormant, generally speaking, the longer it's going to take or the less likely they are to return to their pre-existing baseline function. Right. So one of the things I know that we discuss in office with patients is things to combat that negative side effect of taking testosterone, right? Some guys don't care at all, right? If
they're of a certain age and not interested in having kids anymore and things like that, like, why bother with the extra medication?
Right. Well, I'll use myself as an example. I'll be 40 in a couple months. I do not want any more kids. I've been on
3 girls is enough?
Yeah, 3 girls is enough. And I've been on testosterone for 9 years. Like, I have accepted for myself, I will be on testosterone forever. And I am totally comfortable with that decision.
Which, in that argument, theoretically, if you came off of testosterone,
yes,
your values would go back to where they were before, which was low.
Yeah, maybe. But it would take some time.
And some doing.
It would take some time and doing because I haven't asked my body to make testosterone in a long time.
For sure.
Right. Now, short-sighted on my part, maybe. But for patients that are new to HRT, or they still want to have kids, or maybe they're just not sure they're ready to make that long-term commitment, which is fair.
Totally fair.
There are other agents that can be run continuously with testosterone to help. Simultaneously to try to negate some of those side effects.
Yes.
Right. Now, kind of the big, we'll talk about all of them and which ones work and which ones don't, I guess.
Yeah, for sure.
The gold standard in the States for many, many years was HCG, human chorionic gonadotropin.
Honestly, still the gold standard.
Still the gold standard, right? And what HCG is it's an analog to what's called your gonadotrophs, LH and FSH. LH is responsible for stimulating testosterone, FSH for spermatogenesis. Now, HCG is more analogous to LH, which means it does more LH stuff than it does FSH stuff. But it bypasses the communication loop completely, and it basically stimulates the testicles in lieu or in place of the pituitary gland.
And it's because your pituitary gland thinks that you have enough testosterone. So we're just essentially skipping that part so that we can talk directly to the gonads.
Right. HCG still around, at local pharmacies and maybe a few compounders scattered throughout the country. But the FDA basically screwed that up for everyone.
That is correct.
Yeah, the FDA reclassified HCG as a biologic agent, which doesn't make any sense at all, right? Because that put in the drug class with like Humira and your immunosuppressant drugs.
Mm-hmm.
And if I were to hypothesize why they did it, it's because compounders don't carry a biologics license, right? It's an
Correct.
expensive license. It's hard to get. And compounders don't make drugs. They don't compound biologics, so nobody's going to carry that license.
And
so
I mean, they're battling enough already with the sterile injectables and stuff already.
Yeah.
So like, why would they want to get another license?
because the FDA sucks. So
Hashtag that one.
yeah, FDA sucks. Yeah, we'll start another podcast called The FDA Sucks. That's all we're going to talk about. So there's other options like kisspeptin and ganadorelin. They work in the communication loop. So
And they're both peptides.
yes, they're peptides.
So the availability is definitely far more widely available.
Yep. So what ganadorelin, for example, it's an analog to what's called GnRH. Okay.
Mm-hmm.
GnRH stands for gonadotropin releasing hormone. That is the hormone that is made by the hypothalamus of the brain that tells the pituitary to make LH and FSH.
So we're taking a step back and essentially talking to the pituitary instead of the beginning part of that loop.
Right. It's a decent alternative. The downfall with any peptide medication relative to HCG,
Half-life.
much shorter half-life, extraordinarily shorter half-life rather than HCG. So ganadorelin, really to be effective, like any peptide, needs a way more frequent dose administration,
Mm-hmm.
right?
Mm-hmm.
But from an availability standpoint, you kind of work with the cards that you're dealt.
That's
Okay.
correct.
There's a really cool agent that I know is used more overseas, not in the States, for fertility and gonadal maintenance. It's called HMG. It's human menopausal gonadotropin.
Mm-hmm.
It's basically, whereas HCG, they always say, is taken from pregnant women. HCG is what drives sexual health development and things like that in utero. HMG is basically exogenous LH and FSH, right?
Mhm.
But it's equally balanced. Same idea as HCG, except it's a more balanced LH and FSH stimulus.
Mhm.
Okay. I don't think we even have that in the States.
No,
Nope.
I don't think so. I was going to say, and I mean, there is some fertility specialists that pair well with hormone replacement. So they do have a more variety, which I think that they use FSH specifically.
Yeah, folotropin.
Yeah.
Yeah, folotropin. And then so
There's ways to circumvent that, but that drug's cool.
right. So that drug is cool. Yep. So and then there's one. So anyway, we use those and run them continuously with testosterone
To
To keep-
avoid things from being dormant,
Yeah, to keep the testicles metabolically active and functional.
but
Right.
not necessarily constantly creating its own testosterone.
Right. Well, when you look at peptides, you look at something like GnRH. It's going to stimulate. It's going to have a pulsatile rhythm to it, which means quick hit, drop, quick hit, drop. So you're still getting stimulus to the testes, but I never claim it's exactly the same as your own pituitary drive in it.
Absolutely.
We do see some other agents, some other companies using Clomid and things like that,
Mm-hmm.
which pharmacologically feels counterintuitive.
I mean,
Right.
you can't run it simultaneously.
I just don't see how it would be effective.
Right.
So when you look at clomiphene or Clomid, it's a SERM. It stands for selective estrogen receptor modulator. And how it works is it blocks estrogen receptors on the hypothalamus,
Mhm.
which makes your brain believe I'm estrogen deficient. Because like we talked about, estrogen also can be a negative feedback provider.
Mhm.
However, when you're running it with testosterone, you can still hit that negative feedback threshold with testosterone. So we've had patients come in from other places where, I'm on test and Clomid, but their LH and FSH are still completely suppressed,
Mhm.
right? And in that point, the Clomid isn't doing anything because if it was, LH and FSH would still be detectable,
Correct.
right? So that's why we personally defer to HCG, ganadorelin, kisspeptin, things like
If
that.
you want to just continuously run testosterone.
Right. Because they can't be rendered ineffective by negative feedback from testosterone.
So in that circumstance, we use Clomid, but you would be cycling off of testosterone and doing
Yeah.
Clomid by itself.
Yeah. Or with HCG as a combination modality. Yeah. But we don't run the two simultaneously.
Yes.
Right. And some patients choose to do those ancillary agents. Some of them don't,
We definitely recommend it much harder if anybody puts a question in. It's like the same idea when OBs are asking if you want to tie your tubes after you you have a baby.
Yeah.
Right. As soon as you put hesitation in, we're definitely going to not do it, or they wouldn't do it. So like, it's the same argument when it's like, are you guys looking to have kids? Is it on your mind at all? If there's any hesitation at all, it's something that we're going to push a little bit harder for.
Yeah. Well, and also I think a lot of male patients come in with some low level of apprehension of, I don't know if I want to take testosterone forever. I've never taken it before.
Mm-hmm.
I've never been on it. I don't know if it's right for me.
Mm-hmm.
And that's valid, right?
Yeah, absolutely.
And I'll be honest with you, if somebody was going to take testosterone for 3 to 6 months, right, without it, realistically speaking, their endocrine system is probably going to recover somewhat normally thereafter.
Yeah.
Right. Without too much harm, because the endocrine system wasn't suppressed for an exceptionally long period of time.
They went dormant for winter, and that was it.
Right. But, the longer somebody is on testosterone, right, and the longer the testes are dormant without stimulus, the more difficult it may be to get that endocrine system back.
Yeah.
So, especially for patients where they're not sure they want to be on TRT forever, they're concerned about fertility, it's really advisable. Or you may have scenarios where you have a guy that's got a great total testosterone, but their sex hormone binding globulin is really high. So they've got bad free, right? And yes, there are things you can do to influence sex hormone binding globulin. We don't advise most of them. Yeah. Right. We're not.
Danazol.
Yeah. Danazol, SARMs, other anabolics that is a physician's office. We can't really recommend any of them except for the Danazol.
And Danazol isn't terribly.
No. So, in that case where it's like, hey, listen, raising your testosterone over time will help suppress sex hormone binding globulin. We give you more total, we're inherently going to have more free, but we really want to maintain the fact that you do have pretty good production, right? Then those agents become more important as well.
Yeah. So, we already talked about gonadorelin as something that we kind of pair with. The other thing that we use is anastrozole.
Yep.
Arimidex is
the brand name.
But we use that as a conversion suppression, essentially. So when we were talking about how your testosterone, some of it innately just converts to estrogen, right? That's where we use the estrogen blocker. And when we're talking about this, we're not talking about suppressing estrogen completely, which I think is one of the number one concerns that we hear from people, especially because it's a lot of topic that we hear from podcasts a lot. Right. Everybody thinks you're going to lose bone density. You're going to have a bunch of joint pain and things like that, because the assumption is, and the studies have been, that that would be suppressing estrogen completely. So anastrozole was used specifically for cancer.
Right.
Also.
Yeah. Remission from estrogen receptor positive breast cancer is its original development. And all the anti-estrogen drugs, whether it's anastrozole, letrozole.
Even saying like anti-estrogen is feeling like
bad, right?
Bad.
And I would say, for us, we're not like hardcore pro AIs, but we're not hardcore anti-AIs either. It's just like everything else. It's a case-by-case specific basis, right? Yeah. And just like you said.
And we want to keep you around your baseline. Right. We want to know where we know where your body is comfortable with estrogen. Right. So we want to keep it around there.
Right. And like you referenced, when we look at, when you look at your literature on aromatase inhibitors and on-label drug studies, what are the side effects? Yes, bone loss, cognitive decline, all those horrible things. Those are mechanisms when the drugs are used in a completely suppressive nature to take estrogen to nothing.
Right.
Right. Which is not what we're doing in off-label prescribing. And for reference, like a normal dose of a breast cancer patient in remission of Arimidex may be 1 milligram every day.
Which they probably do have all those symptoms, the bone loss and the joint pain and I have hot flashes and all of that. Like, yeah, for sure.
Yep. Whereas a male patient may be on 1/3 of 1 milligram a week or something like that. And it's not something that we automatically defer to either, and that goes into individualized case management, right? So when we look at, frequency of administration, I would make an argument. The more frequent you take your dose, the less likely it is that you're going to need a aromatase inhibitor.
Correct.
Right. Somebody does a big dose once a week and they get their testosterone's peaking at 2000. Yeah.
Their estrogen's up there too.
They're going to aromatize a lot. There's plenty of patients we've seen that do, more frequent microdosing, daily administration where it's not necessary because their peaks and valleys are relatively stable. And then they don't have that big window of opportunity for aromatization at an excessive rate. So,
and really what it's doing is it's keeping it from converting to estrogen. So that means that it's just staying in testosterone. It's not being eaten.
Yeah.
It's not going away.
Yeah. So how those drugs work is they bind to the heme ion of the aromatase enzyme. So it binds to it so that testosterone doesn't. Right. But yeah, I mean, we acknowledge we definitely don't want our male patients to have no estrogen.
For sure. Estrogen has its benefits.
Yeah. Yeah. I mean, I've had moments myself where I took my estrogen too low and felt like I was going to blow my pec and my Achilles in the same workout. So those are used, or sometimes, people will use myomin or things like that.
Yeah.
Right.
And honestly, with the lower doses, it's not like we're experiencing any side effects or anything like that. Very rarely do we see side effects.
Right.
Like some people claim heartburn and things like that, but very rarely.
Yeah.
So those are the primary things that we use with our hormone replacement program. There is obviously ancillary peptides and things like that we could be considering pairing, but those are the meat and potatoes of what you experience as far as male hormone replacement.